안녕하세요.
Hello, I'm Dr. G. Daekyung from Seoul May Orthodontic Clinic. I hope you found the previous lecture helpful. Today, I'd like to talk about something more clinically focused. I'll be giving a brief overview of IPR and attachment bonding. I'll be discussing how to perform IPR, how to bond attachments, and how to place additional auxiliaries such as buttons. IPR generally refers to the process of carefully removing a small amount of enamel from the sides of the teeth. This procedure is used to create space, allowing for controlled tooth movement within the newly gained space. There are various pros and cons to consider. One should be mindful of potential issues such as hypersensitivity or an increased risk of caries. After performing IPR, it's important to finish with careful polishing and fluoride application to the treated enamel surfaces. Let's take a look at several cases. These aren't particularly complex. These are mild Class 1 crowding cases where space was easily gained through simple IPR procedure and treated using clear aligners for alignment leveling. There are numerous studies that have examined proximal enamel thickness of teeth. Based on several papers, we can say that around 0.5 millimeters of enamel can be safely reduced in the anterior region and approximately 1 millimeter in the premolar and molar regions. As I mentioned earlier, the shape of the teeth can also affect the outcome of IPR. Triangular-shaped teeth are generally easier to treat with IPR, allowing smoother reduction and improved aesthetics. This is something most of you are already familiar with. So there are a few considerations when performing IPR. These are points we need to keep in mind throughout the clear aligner treatment. In cases of severe crowding, it's better to divide the IPR into multiple stages rather than performing it all at once. I'll also show you a video demonstrating this approach later. When using a high-speed burr for IPR, it's recommended to approach from the lingual side. As mentioned earlier, due to concerns like caries or hypersensitivity, it's important to finish with polishing and fluoride application. Personally, when performing IPR in the range of 0.4 to 0.5 millimeters, I prefer to use a high-speed burr specifically designed for IPR procedures. It's extremely thin. With careful technique using this burr, I believe you'll find that IPR is not difficult to perform. Burrs are available in various thicknesses such as 0.3 millimeters, 0.2 millimeters, even 0.08 millimeters. In some cases, IPR is carried out using these dedicated burrs attached to a dental engine. These burrs come in various thicknesses, so you can select the appropriate one based on these things. Let's take a look at the sequence. In cases where the interproximal contact is tight, a strip can be connected to a handle, which is attached to an engine-driven handpiece. In such cases, there are a few precautions to keep in mind. It's important to use coolant, either air or water. Personally, I prefer using water spray. Just make sure not to direct the spray toward the patient's face. With that in mind, proper water cooling is essential. After completing IPR, you may notice that the teeth tend to slightly shift due to the PDL space. You can use a gauge to check the thickness on this side. Then, after completing IPR on the other side, place a space gauge such as a 1 mm or 2 mm gauge on the first side to get an accurate measurement on the IPR site using the gauge. This is a practical clinical tip. And finally, be sure to finish with a polishing strip and apply fluoride as needed. As I mentioned earlier, there are some precautions to keep in mind, especially when using a high-speed burr. Let's take a look. When approaching from the labial side, the result may not be as aesthetic, and it can lead to defects. That's why I recommended performing IPR from the lingual side. Of course, that doesn't mean it's acceptable to cause defects just because you're working lingually. Since any surface defects caused by IPR are irreversible, I recommend performing IPR from the lingual side whenever possible. Using polishing tools, whether handheld strips or mechanical ones, is essential to properly finish the surface. Now, let's take a look at the video. The clip shows a case where IPR is performed from the lingual side using a high-speed burr. When doing this, there are a few points to be mindful of. Typically, we use a mirror to retract the cheek, but repeated contact with the mirror can cause irritation to the patient. It can be quite uncomfortable for the patient. In such cases, I personally prefer to retract the cheek by hand. Now, let's look at another example. This one uses a low-speed strip to perform the IPR. In this video, air is being used for cooling, which is acceptable. However, in my opinion, using water spray is generally a better option. Just be careful not to direct it toward the patient's nose. Next, we're using a hand strip to create minor spacing. There are a few precautions to keep in mind. If you pull the strip out forcefully like this, it can cause trauma to the gingiva or the lips. As I mentioned earlier, placing a cotton roll for protection or manually retracting the lip can help prevent such issues. With these techniques, you can perform simple IPR or polishing safely. It's not too difficult. And this is the appearance of the teeth after completing IPR. The key is to ensure that IPR is performed cleanly and precisely. At this point, I'd like to present a quick quiz. Of course, there may be different opinions depending on the clinician. I've given this concept a name, strategic IPR, which refers to the idea of strategically planning the position and sequence. So here's the question. We're planning to perform IPR in the anterior region. How would you sequence it? Take a moment to think about it. 1 second, 2 seconds, 3 seconds. Performing IPR in the anterior region is relatively easy. Once you create space and bring the teeth together, you'll often find that even more usable space becomes available. The key is to start with the less crowded areas first. This helps generate some space. The numbers shown here indicate the recommended sequence for performing IPR. Let's take a look at the second quiz. 1 second, 2 seconds, 3 seconds. As mentioned earlier, based on the same reasoning, we start IPR from the more accessible areas first. Once some space is created, we proceed with IPR according to that sequence. That would be a logical explanation for this approach. So if the amount of reduction is uneven, it can be quite undesirable, not only because it affects the overall appearance, but also because removed enamel cannot be restored. That's why it's important to carry out IPR with great care. We also need to inform patients in advance about what to expect. The idea of removing part of their teeth can sound frightening, so it's essential to explain the safety of the procedure beforehand. But sometimes, no matter how much we explain, it may not be enough. That's why I prefer to use official materials, such as the clinical papers I showed earlier, or brochures published by orthodontic societies. And even when we do explain it, I think it's better to avoid phrases like "we're going to remove part of your tooth." And I personally prefer using softer expressions like "we're going to reshape the teeth." This is the brochure published by orthodontic societies that explain interproximal reduction. Keeping these materials in the clinic and sharing them with patients can be helpful in improving their understanding. Now, moving on to the second topic, attachments. The design of attachments can vary depending on the aligner brands. For example, in the case of Magic Align, attachment templates are typically delivered in 4 quadrants. Some companies provide attachment templates that are designed to be placed all at once. Trying to bond all the attachments in a single step can be quite challenging. Even if the template is delivered as a full arch piece, I personally recommend dividing it into sections, such as quadrants or even sextants, separating posterior and anterior regions. As many of you have already experienced, bonding all the attachments at once is quite challenging. I'm sure all of you are already familiar with the standard bonding routine. Just follow your usual bonding routine. Make sure the attachment template is properly seated, and proceed with polishing and removing any excess resin. Finally, check the bonded attachments to ensure there are no defects or bonding failures. Here's an important precaution. Always check the fit of the first aligner. I'm referring to aligner number 1. Once the attachments are bonded, if the fit is off, it becomes difficult to determine the cause, whether it's due to a manufacturing issue with the aligner or something else. So, it's important to place the first aligner and check its fit before bonding any attachments. During resin packing, especially when using flowable resin, extra care should be taken to avoid air bubbles. When using a hard-type resin, defects can often occur around the margins. These areas need close attention. In such cases, it's important to reinforce the margin area with flowable resin to correct defects, just as you would do in resin filling procedures. You can also use an explorer to eliminate any air bubbles. As you can see in this image, this is one of my own cases. This is an example of what not to do. I'll be honest, this is a mistake I've made myself. It's exactly what you shouldn't do. To improve adaptation of the attachment template, there are a few useful tips when placing the attachment template. Some clinicians use a cotton roll here or press with their thumb to secure it in place. But what often happens? You can see poor adaptation near the cervical margin. It lifts. To avoid this, I recommend using your other hand to press gently with your fingernail around the margin to improve adaptation. This is often difficult to do alone. In cases like this, it's best if two hygienists can work together during the procedure. Let's take a look. Personally, I tend to use flowable resin for attachment bonding, although some of my staff members prefer using hard resin. What matters most is achieving a strong and accurate bond. So once the template is well adapted, make sure to press down both on the occlusal surface and the cervical area to prevent any lifting. Then proceed with light curing to secure the attachments. When removing the template, it's being removed anteriorly in the video. You can see the attachment here. In this case, removing the template from the lingual side can help reduce the risk of attachment debonding. It's a more efficient method. Now, regarding attachments, there are also important precautions that should be communicated to the patient. Some clear aligner patients may think, isn't it just about wearing the aligners? There are still patients who say things like this. It seems that attachments aren't as noticeable as brackets. But you can explain that attachments act like handles that help the aligners fit more precisely and move the teeth more effectively. I think the explanation can help patients better understand the need for attachments. This is the resin I use when placing aligner attachments, and I've found it quite useful. So I'd like to briefly introduce it. It's a product from GC, and while the manufacturer highlights several features, as I mentioned earlier, what stands out to me is its improved wear resistance and excellent shape reproduction. Ultimately, the adaptation at the interface between the attachment and the aligner plays an important role in facilitating effective tooth movement. That's why I consider material properties particularly important. Now, moving on to the final topic, accessory bonding. This is something I personally found quite troublesome at times, so I'd like to share a few practical tips with you. So here we're placing a button. In my experience, prefabricated buttons often don't have long-term bonding strength. That's why I prefer to create my own button using resin. You probably have these O-rings in your clinic. When I need to place elastics, especially stronger ones, I often use blue O-rings or separation O-rings. One important tip is to pre-cut the O-ring with a pin cutter before positioning it. When removing the ring, this prevents the button from debonding. It's a simple but practical tip. So by using this method, you can successfully place a well-bonded lingual button. Depending on the case, you can also use a power chain. It's a useful clinical tip in practice. I hope you found this session useful. Since the focus was more clinical, I imagine it may have provided you with some practical insights. I truly hope the content was valuable for your daily practice. I look forward to seeing you again in the next session. Thank you.